Hello, this is Muthanna Al-Quraishi from Iraq. We have a special guest with me, Dr. Hadi Abu Hantash from Jordan. Dr. Hadi, would you please tell us briefly about your presentation this morning?
Thank you, Dr. Muthanna. It was my honor actually to have the opening presentation for the GIS 2023, and I want to wish the board a successful meeting. I chose to talk about high thrombus burden in acute coronary syndrome.
Yes.
And I presented two cases. One of them, ST elevation myocardial infarction with high thrombus burden, and non-ST elevation myocardial infarction with high thrombus burden. Both of them had common grounds. They had ectatic vessels, relatively young patients with large thrombus burden, which made me decide on a deferred PCI strategy, mainly stenting. The reason I chose that is because the patients were stable once I did the angiogram, and that gave me the chance to do the deferred stenting and come back complete the stenting within 48 hours while the patients were on dual antiplatelet therapy, enoxaparin, and G2B3A inhibitor.
So in your opinion, large thrombus burden need special consideration and management?
Yes, I mean, large thrombus burden is in the eye of the beholder, but you have to grade the thrombus according to the known scoring system. If the thrombus has a grade of 3 and above, or it's a totally occluded vessel, that's a high thrombus burden. One thing which we interventionists always think that when we do acute coronary syndrome angiogram and we see total occlusion, we relay that to a high thrombus burden. But the data showed us it's only 50% of the totally occluded vessels in acute coronary syndrome actually have high thrombus burden. So.
Then the therapy differ from the usual interventional procedure?
Yes, deferred stenting is not a routine recommendation by guidelines. However, in patients who have a very high thrombus burden, and it's very important that they're stable. I mean, if the patient is unstable with continuing ischemia, continuing ST changes, or hemodynamically unstable, you cannot defer it. You have to do it immediately. However, if the patient is stable, showing signs of less ischemia, then you can.
Then, in your opinion, what difference in form of antiplatelet therapy and anticoagulant in a patient with large thrombus burden?
All of the patients, we like to give them dual antiplatelet agents, keep them on low molecular weight heparin for at least 48 hours. There are data from randomized data showing us that you can do it anywhere from 24 to 72 hours. And actually observational data showed you can do it up to 5 to 7 days while they are on anticoagulation and dual antiplatelet. One thing important is you defer stenting when the patient, you manage with a minimal type of intervention like wire, balloon, or aspiration thrombectomy to get a TIMI 2 or 3 flow. If you don't have that, that's not a good strategy to defer because you have to have a TIMI 2 or 3 flow before you do the deferral. One thing we talked about is the discharge medication.
Yeah.
All of them have to be on dual antiplatelet. Both of my patients had ectatic vessels. One of them had a residual large filling defect, so I elected to give them rivaroxaban for 2 weeks. And of course, that's not supported by data and evidence. I thought that might be helpful to the patient.
So the addition of direct anticoagulant is an optional, mainly depend on observational study. What about the duration of this?
I gave it only for 2 weeks.
For 2 weeks.
Because no doubt about it, if you do the triple therapy, you might get in trouble with bleeding, and you don't want to get that.
Thank you, Dr. Hadi. Very nice presentation as usual.
Thank you, Dr. Muthanna. It's my pleasure.